Thank you very much for the opportunity to speak, and I think this topic lends itself to skepticism, so let's talk about some data. So if we look at, this is Karen Hoffman's study, Dana-Farber, for the first time looking at our population-based database in SEER, looking at biopsy-related data to look at the proportion of men diagnosed with various forms of prostate cancer stages. And we see that when we look at the breakdown, very low risk and high risk patients represent approximately 50 to 60% of the patients diagnosed in the United States. And that category of low intermediate risk prostate cancer, which I would argue if there is a group of patients that should be considered for a type of focal therapy, it would be these men. So it's not an insignificant number in a group that should be studied. So my only disclosure, I'm a PI of a multi-center trial looking at MR-guided high-intensity frequency ultrasound, in which today I'll give some introductory remarks. So really I want to outline the evidence to establish the role of studying focal therapy as a viable treatment option, and we'll get through each of these subjects as we move along. So Freddie Hemdy's in our audience today, but this was a very provocative slide that was a secondary figure in his paper comparing observation of radiation therapy to surgery in a randomized trial in the UK. And what we see in the active monitoring group, about 50% of patients by 5 years required some form of treatment. I would argue a significant proportion of those patients had some form of reclassification of Gleason grade or stage. And to discuss a patient, to tell a patient who's been on surveillance that all of a sudden you need radical treatment within 5 years, that discussion may be difficult. In fact, if we can expand that curve more than 5 years, beyond 8 and 10 years, then we have an opportunity to impact a patient's quality of life and significantly impact prostate cancer care. So how good are we at determining if we can identify Gleason grade 7 or higher lesions in the prostate in the setting of multifocal disease? I think there's no argument that prostate cancer is multifocal, but with the advent of active surveillance, many of these patients with low-risk cancers can be monitored. So this is a study of whole mount specimen looked at, and the correlation between tumor volume and that being the highest Gleason score is quite high. So that gives us insight that perhaps if we can understand better to characterize within the prostate what the highest tumor volume is or highest Gleason score, we would be able to identify the index lesion or the dominant area in which treatment can be administered focally. And while imaging provides that role to look at both of those factors, as Alberto mentioned and outlined before, in fact, Gleason grade and volume are our two most sensitive predictors of high-grade cancer and prostate cancer. So if we can guide our diagnosis and treatment using imaging and biopsy criteria, we have gone a long way. So this is data that looked at MR-targeted biopsy as compared to whole mount specimen. The caveat here is these men went on to get surgery, so there's an inherent bias. But if we look at MR-targeted biopsy in men, what we really want to know is men who were diagnosed with Gleason 6 disease, how many of those men actually had higher Gleason grade disease, so misclassified, or men with Gleason 7 disease who actually would have had higher Gleason grade disease. And we see that we do a good job at classifying disease in many risk strata, rarely finding very high risk disease in the setting of low or intermediate risk disease in the era of MR-targeted biopsy. But let me give you more insight and more clinically relevant discussion about what about MR-targeted biopsy treated and subsequent biopsies afterwards in the era of focal therapy and our idea of reclassification. So when I first started 4 years ago, we said, let's actually evaluate this in the era of MR-targeted biopsy. So we initiated a study looking at electroporation, a form of image-guided focal therapy in which we place probes, turn on current, cause irreparable damage to the cell membrane and subsequent cell necrosis that Jonathan Coleman has demonstrated in the lab very nicely. So we took men who had undergone MR-targeted and systematic biopsy, underwent treatment focally. These are image-guided treatments under ultrasound guidance, subsequently underwent a repeat biopsy guided back in the areas that were previously diagnosed. If Gleason 7 disease was subsequently diagnosed, a retreatment was allowed, and a secondary biopsy was done at 12 months. These are all men with Gleason 3+4 or small volume 4+3 disease. So I'll give you some preliminary data, as this study is still ongoing, for the purpose of this conference, and we see most of these men. So we treated 20 men. 1 man could not undergo treatment due to cardiac issues related to the electroporation, so we stopped treatment. But of the 19 evaluable patients, we see these men obviously all had image-detected lesions. We see these are all Gleason 3+4 cancers, and almost half of those patients had multifocal Gleason 6 initially identified on biopsy. If we look at the characteristics of this group, 19 of these patients, all these patients have undergone 3-month biopsies, and 11 so far have undergone 12-month biopsies. And we see we actually are treating throughout the gland, and these are not selected for location within the prostate, whether it's close to the rectum, urethra, neurovascular bundle. So as we look at these patients, at 3 months, if we look at any cancer detected, we see that we start seeing that in the ablated area and recurrence in those areas, those are probably related to both our ability of the technology to ablate and probably our ability to localize. But I really want to focus on this idea. We were wrong in classification up front with our best tools, with MRI and with MR target and systematic biopsy, and we see we were wrong in approximately 27% of those patients. So this really gives us an insight that, you know, we're not about the estimation of what we can tell with regard to classification in the modern era. So that introduced me to this topic, which is a trial work that's currently undergoing over 7 centers in the United States that we are the national PI, in which patients underwent, again, MR-targeted biopsy. In this trial, patients underwent high-intensity frequency ultrasound. This was done in the MR suite. So this is under real-time MRI with real-time thermometry to assess temperatures during treatment. We can localize very focally. It's image-guided. So the criteria for this study are men with less than Gleason 4+3 or less disease, identified in 2 adjacent sextant cores on prostate biopsy. These are obviously all have to be MR-detected lesions. And our outcomes were measurement of adverse events and 6 and 24-month pathology. So far, we've treated 17 patients in our center, and across the United States, we've treated 55 patients. Again, as we see, these are your typical low, intermediate, and favorable patients. These are all Gleason 7 cancer patients with cancer, multifocal cancer in half of these patients. Again, so a very similar cohort. So when I look at this data, we can't currently, it's under our DSMB, so I'll give you some representative cases and give us some insight that we've learned. So this is our first patient. It was a 48-year-old who underwent treatment, obviously good quality of life. He had a 33-gram prostate, an MR-detectable lesion measuring approximately 1 centimeter. This was a PIRADS 4 lesion that we see both on the diffusion-weighted and the T2 images located on the right side in the transitional zone. This was our prostate biopsy. Our MR-targeted biopsy and our systematic biopsies were concordant with, in fact, the imaging of a lesion that was identified in the right transitional zone. These are some images from within the treatment itself. As you can see in the upper left-hand corner, during treatment itself, we actually monitored temperatures within the prostate. So when temperatures achieve what we consider kill temperatures of above 70 degrees Celsius, that's what we're aiming for. We can adjust frequency, we can adjust duration, and other factors during the treatment to achieve those temperatures in real time. So many of these patients actually during the treatment were doing significant adjustments. As you see below, that's a temperature curve, the correlation between what's being measured at a single voxel and also across the entire image is being also displayed. And this is our post-contrast image in these patients. What I want to really take away from this is if you compare the pre-treatment MRI and the post-treatment MRI, we do a significant margin around the cancer. This is across 6 slices and 3 millimeter margin slices and about a 5 to 6 millimeter margin around the cancer. In this patient, he had no side effects after treatment and currently is being evaluated for functional outcomes. This is patient number 2, 64-year-old gentleman, again, very typical patient with good quality of life outcomes. We see a lesion in the left base, again, measurable and detected on MRI. This was a PIRADS 3 lesion. This was our systematic biopsy and MR-targeted biopsy. Again, concordant in the left side. This is the treatment images. Again, we see an area that was much smaller in the post-treatment area and subsequent treatment with a significant margin of treatment. And we're able to achieve these treatment margins with very minimal impact of side effects. And again, this data will be reportable when we have completed our trial. This is our last patient. Not every patient is a perfect candidate. So this patient is a 58-year-old. Again, typical characteristics, very healthy gentleman with good functional outcomes. He has an anterior lesion in this situation, as we see both detected on MRI and outside. The MR-targeted lesion at the left transition zone anteriorly is positive. He underwent treatment, and something very different happens. During treatment itself, with the feedback given with MR thermometry, as you can see, that anterior area is getting no dose. Despite our abilities to change the frequency, change the dose being provided, we were not able to achieve and heat that area. And this is a very interesting case to let us know that other forms of HIFU with ultrasound guidance without real-time temperature thermometry can have some limitations in determining success in treatment. This patient, after without multiple maneuvers to achieve temperatures anteriorly, we stopped the case, and he underwent radical prostatectomy. So as I move along, when we talk about these patients, enroll these patients in trials, treat them, managing their expectations is key. And it's very important when counseling these patients, the discussion regarding whole gland treatment and focal treatment must be very separate, in the sense that the idea of cure versus delaying radical treatment is a very real phenomenon when it comes to focal therapy when compared to radical prostatectomy or radiation treatment. And retreatment is not uncommon after focal therapy. This is a study at UCL which determined approximately 15% of patients in hemiablation required retreatment due to gradable cancer in the ablated area. In our study initially with electroporation, we also see approximately 15% of patients who needed retreatment after initial treatment. So patients should be informed that retreatment in the area of focal therapy is expected within the spectrum of management disease to delay radical treatment, and this really should be built in our trials and our ideas when we move forward. In regards to morbidity and adverse functional outcomes, I think it's very clear that focal therapy is safe, and as more data and our data will come out determining its impact on functional outcomes, it's important to realize that sexual function, for example, is not just potency. Many of these men have other factors that bring them to focal therapy and should be addressed that haven't been addressed previously in whole gland treatments that we see, specifically about ejaculation, orgasm quality, and chronic pain. And this is our data from our electroporation study. Again, these were men who were evaluated with electroporation as a form of targeted therapy, and we evaluated erectile function. And you see there's a stable erectile function across that remains intact with a IEFF score above 20 in these patients long term, with immediate return back to baseline in most patients across the median as well. However, when you look at ejaculation assessment, this is through the MHSQ, we see a significant decrease in ejaculation quality and volume, which is associated with bother in these patients. Again, something that's not been measured in our literature in regards to radical treatment that should be addressed in patients who've had focal therapy. So patient preferences regarding sexual function expectations should be elicited and discussed prior to discussing and treating patients with focal therapy. So in conclusion, focal therapy of a tumor provides an alternative treatment for men with low intermediate risk prostate cancer. I think the idea that treating the index tumor, surveying low-risk tumors, overcomes some of the challenges associated with multifocal cancer. And finally, the goals of focal therapy should be separate from those that we currently counsel patients in regard to whole gland treatment. Thank you very much.